How can you tell gout from pseudogout? When it comes to joint pain, two conditions that often get confused are gout and pseudogout. Both are types of arthritis caused by crystal deposits in the joints, but they have distinct differences that are important to understand. Let's break down how you can tell them apart. First, the cause and type of crystals involved are key. Gout is caused by the buildup of monosodium urate crystals. These crystals are needle-shaped and can be identified under polarized light microscopy as negatively birefringent. On the other hand, pseudogout is caused by calcium pyrophosphate dihydrate crystals, which are rhomboid-shaped and positively birefringent under the same microscopy. Next, let's talk about which joints are typically affected. Gout often targets the big toe, a condition known as podagra, but it can also affect other joints like the ankles, knees, wrists, and fingers. Pseudogout, however, most commonly affects the knees and wrists, but it can also involve hips, shoulders, ankles, and even the spine. Risk factors also differ between the two. Gout is more prevalent in men and is linked to a high purine diet, which includes red meat and organ meats, as well as alcohol consumption, especially beer. Obesity and certain metabolic conditions can also increase the risk. Pseudogout, in contrast, tends to occur in older adults and affects men and women more equally. It has no clear dietary link and is often associated with aging and metabolic disorders like hemochromatosis or hyperparathyroidism. Both conditions cause sudden, painful swelling in the joints, along with warmth and redness. However, pseudogout attacks can last longer, sometimes days to weeks, and may mimic other joint diseases like osteoarthritis or rheumatoid arthritis. To accurately diagnose these conditions, healthcare professionals often perform a joint fluid analysis, known as arthrocentesis. This test can reveal the type of crystals present in the joint fluid. In gout, you would find needle-shaped, negatively birefringent monosodium urate crystals. In pseudogout, the analysis would show rhomboid-shaped, positively birefringent calcium pyrophosphate crystals. Serum uric acid levels can be elevated in gout but can also be normal during an acute attack, making this test less useful for diagnosing pseudogout. X-rays can also provide insights. Pseudogout may show calcification in cartilage, especially in the knees and wrists, while gout can cause erosions and cystic changes in the bone near the joint. Ultrasound can further help distinguish between the two conditions by showing different patterns of crystal deposition. Gout crystals tend to deposit on the surface of cartilage, while pseudogout crystals are found within the middle layer of cartilage. Both gout and pseudogout respond to anti-inflammatory treatments, such as non-steroidal anti-inflammatory drugs, but their management may differ based on underlying causes. In summary, distinguishing gout from pseudogout relies on joint fluid analysis to identify the type of crystals, along with clinical presentation, risk factors, and imaging findings. Both conditions can cause acute joint inflammation, but they differ significantly in crystal type and typical joint involvement. If you suspect you have either condition, it is essential to consult a healthcare professional for an accurate diagnosis and appropriate treatment.